We're recording, but
okay.
We can.
So let's just check the
Cool.
audio side. So if you don't mind saying something, Andy.
So just doing a sound check here with Gandhi.
And I'm sitting opposite Andy, so we can see how this sounds.
Good.
If you don't mind saying something, Andy.
So just doing a sound check here with Gandhi.
And I'm sitting opposite Andy, so we can see how this sounds.
So Gandhi, we've got people here on YouTube before we start recording.
Yeah.
And the people on the podcast can't hear this bit. This is YouTube exclusive content.
Exactly.
What are we doing here, Gandhi?
So we mentioned this in our last episode. We're going to try and do a little bit more for you guys. And one of the things that we've got is a behind the scenes look at how Andy and I make this podcast. So we're going to be looking back and forth at the camera because it's good practice too, so you can actually see what we're doing. But once we get started, we apologise if we forget. This is our first time doing it. But yeah, we wanted to show you guys effectively how we make this, and we thought we'd start with a really interesting one because we're talking about video consultations themselves.
Yeah. Oh, how fortuitous. So
exactly.
So in terms of what you're going to see on YouTube, we are going to not edit it or minimally edit it so that you get a true behind the scenes look. So there might be some times where we kind of goof up or something goes wrong. We're going to keep the YouTube rolling, but the actual podcast will be edited. So
yeah.
Right. So without further ado, shall we?
Let's get started.
You're
going to see a brief pause. It's just as part of our editing and stuff, so don't think that we've gone all shaky or anything. But yeah, this is the whole recording process. So I'm going to count Andy down. So
hello and welcome to the next exciting episode of the eGPLearning podcast. I'm Dr. Andy Foster here with
Dr. Saying Gandhi.
Fantastic. So Gandhi, what are we talking about today?
Well, today we're talking about video consultations, pros, cons, and what exactly it is, because not everyone is aware of it, although it is a growing field of primary care and medicine as a whole.
Yep, and it's one of those things where there's so many adverts on TV now that you almost can't escape video consultations.
Well, you'd think that, but it's interesting. I spoke to a couple of people the other day who haven't even heard of several of these companies we're going to be talking about, and that's people within primary care themselves, so it's an interesting thing. It may not be as fully aware as people think, but yeah, we'll see.
Good. And so Gandhi, we're experimenting with something else new today. So
yeah, so a couple of things, guys. So we're actually recording this episode live on video. So for those of you that watch us on YouTube, you'll be able to actually see what it looks like. And the video footage is a full behind the scenes look at what we do. So you get to see, first of all, my house, because that's where we're recording. And secondly, any goose or anything like that that may be not exactly apparent on the podcast, well, you'll be able to see on the video version. So yeah, have a look.
So it should be really exciting. And the other experiment is Patreon, Gandhi. So you're best placed to tell people about this.
Okay, so we've been doing this work for about a year now in terms of providing the podcast and everything for you, our listeners. And we hope you find it really useful. We do this completely free. And we've kind of been thinking how we can maintain this because both Andy and I are busy clinicians and whilst we love it, we want to make sure that we can keep doing this ongoing. So one of the things that we would really love is if you, our followers, can support us. This is by no means mandatory. We are making this completely optional for you. But if you are interested and like the stuff that we put out, we would love it if you could support us by signing onto our Patreon account, and the link will be in the show notes and stuff. But effectively signing up, and all it is a couple of small amounts, so $1 or $2 a month that is paid on a regular basis to support us. For the extra function, well, we'll talk about that towards the end. But in brief, we just wanted to mention it and listen out at the end for more details.
Yeah, fantastic. And also a shout out to our sponsors, HTN, Health Technology Newspaper, an innovative daily news opinion website for the Health Tech Network, www.thehtn.co.uk. And also news, they've recently had the HTN Awards out, so sign up for HTN and have a look at those things. Oh, and Gandhi, we're getting involved with something on the 24th of January.
Yeah, so HTN are doing something slightly innovative. They're actually having an online conference, and this is in January, so they're calling it the HTN Week. So this is the third week in January, starting, I think it's week effective the 21st of January. And they've asked Andy and I to basically host one of the afternoon sessions. So on the 24th of January, Andy and I will be hosting a webinar session covering a variety of topics such as our 5 top clinical apps, how to use social media as a doctor, and also using technology to enhance your CPD collection. So these are topics both Andy and I love talking about. definitely recommend tuning in, guys. You'll be able to get some really cool content, hints and tips and that kind of stuff. And yeah, we're glad that HDN are able to support us in doing this. We want to get these kind of messages out, and I guarantee you're going to get some great tidbits of information.
And it's going to be fantastic. We're going to attempt to do the podcast live, so there'll be an opportunity to interact with us on social media, and on the video platform. So it's going to be very exciting, and hopefully nothing goes wrong. Fingers crossed.
Fingers crossed.
So Gandhi, we've had some feedback as ever on social media from our last podcast.
Yeah, so regular shout out to our really cool followers. So we've got JC Melody, Sonali Kinra, NCGPA, Knots LMC, DMC, got a few people, and they're all mentioned in our comments. Special shout out to SoMe Doctors, so they're on Twitter. It's basically a Doctors on Social Media group who've got behind us recently and been retweeting us, and as well to @Annalise2406. So she gave some really good feedback on our most recent episode, the NHS app, and particularly how that works with other platforms and stuff. So we may have some further content coming from her in the future, but definitely have a look at those comments. We'll link in the kind of link to have a look at that kind of stuff. But interesting prospects in terms of how that can work.
Fantastic. And I think Orca retweeted as well.
Yeah, so we mentioned them in the last podcast, talking about the NHS app. So Orca is an organisation that basically reviews apps for the healthcare system, and they've just recently linked in with the NHS App Library, and yeah, they've been commenting, and we've been speaking to them about some potential options as well in the future. So hi Orca, hope you guys are all right.
Hi guys. Good. So, and I suppose we normally update people at this point as to what we've been up to in the week since the last podcast, Podblast.
So what have you been up to, Andy?
So I have. I'm starring in a video about how to manage the common cold.
Okay.
We've done some recording with the guys at NCGPA.
Yeah. So guys, I've seen the initial draft of this. It is awesome. I really enjoyed watching this, not just from the information delivery perspective, but yeah, and he's got, I think, potentially some acting capabilities.
You can check out my acting skills in this. There's an attempt to make it humorous, which is a thin line to walk on such a dry topic. So I've been up to that. Also, did another sketch for the blog after a bit of a gap of content. So it's called Dr. Damocles. So have a look at that and see what that looks like. Just been carrying all my normal duties, been seeing patients at the practice, all the usual stuff. Yeah. Gandhi, what have you been doing?
I guess the other thing to mention as well, Andy, is talk about your sketches. We've got some information for our listeners later on with regards to the Patreon stuff.
Good, link in.
But we'll come back to that. So what have I been up to? So those of you that know me personally and follow me a little bit on social media will know that a few weeks ago I did something absolutely mental, crazy, and very important to me. So I went on a pilgrimage to Iraq and walked from Najaf to Karbala, which is 86 kilometres.
My goodness.
In the Iraqi desert heat, and I did it in 40 hours with a colleague. And my parents actually also did it, but they were a little bit slower than me. I'm actually putting a blog post about this up shortly, so if you guys are interested and want to hear about it, feel free. It's more for people from my community, because hints and tips on what to do, because this is an annual thing, and what the actual pilgrimage is and stuff. If you are interested, feel free to have a look. But yeah, that's probably the biggest thing I did over the past few.
I think it will be an interesting blog post, because I'd love to see what it was kind of all about as well. So hopefully there's a bit of background in terms of what
so there's some information about what it was and stuff. Admittedly, most of that post is going to be about actually my kind of perspective on how to do it and stuff, because that's what I've been asked to write. But yeah, feel free to have a look, guys. Other stuff, so I continue to do the Tip Thursday thing, and one interesting tidbit, so we've kind of merged the Tip Thursday and the Podblast a little bit, because it's now available for you to listen to. And thank you guys for listening to it, because you seem to have taken to the podcast side of it really well. In addition, a couple of weeks ago, I created some new content called EGP Drama. So this stands for, great name, I know. And thank you to some of our listeners who from the eGPLearning Facebook group actually came up with the name. So it stands for eGPLearning General Practice Disaster Record and Management Action Plan. Yeah, it's a bit of a mouthful, isn't it? But effectively, it's my version of an adjunct to the business continuity plan many practices have, and it's designed to try and support you to make sure you've got all the relevant information. After seeing some practices really struggle when they've lost key members of staff, like, for example, a practice manager, for whatever reason, and having that information at hand, it's just, I find, really useful. It's completely free. You can access it if you want. Admittedly, you may need to sign up to my emailing list to get it, just because I offered it for free for a couple of weeks, and then after that, it's going behind my kind of like emailing list war, but as I said, it's completely free, and comments I've had are really useful. Interestingly, Nikki Kanani, I think, is going to be tweeting about it shortly as well. So for those of you that don't know, Nikki Kanani, our current primary care director and stuff. So yeah, and by the time you guys are listening to this, I would have had my first seat on RCGP National Council. So
can you tweet live from that, Gandhi?
Well, it's slightly live. I think it's delayed by an hour or so is the current rules.
Okay.
So
cooling off period.
Yeah, a little bit. I think just to. I'm still trying to go through the amount of paperwork that comes with it. If I'm being honest, it's quite a lot. But yeah, as always, if anybody wants to put some of their perspective through, I will be reaching out on social media platforms and stuff to ask people their perspectives on what I can talk about, because I know some of the stuff is completely confidential and unable for me to discuss. But what I can, I will put out there. And if you guys give me your comments, I'm more than happy to feed that back. It is my role as a national representative. It's something I'm hoping I'll be able to take forward for a lot of you, and yeah, keen to put those messages across.
Cool.
That's about it, really.
Wow, that's it. That's a lot. So without further ado, we'll move into the main body of the podcast. So you may have seen the adverts on television. You may have read all about it in Pulse, in GP Online. The video consultations are coming. And are they good? Are they bad? I'm not sure anybody knows right now. People certainly have their opinions. So today we're talking about video consultations. And we're just going to... we're by no means experts on the topic. I myself have practically no experience of working with video consultations, although like everybody else I've read some of the articles about it and seen some of the adverts online and spoken to people who have used it or have been doctors behind it. Gandhi, you've had a bit more experience, I think.
Yeah, so I've actually been working for one of the companies we're going to talk about recently. To be clear, I no longer work for them, purely and simply because of a timetabling issue and my availability and that kind of stuff. But it's definitely an interesting perspective. I have done some other video consultation work prior to that in more like an NGO format for people within my community and stuff. But that was more kind of informal, supportive, to help with disaster management and that kind of stuff in events and that kind of thing. But in terms of more formal work, yeah, that's the most recent stuff I've been up to. And also actually been doing some work for our local alliance. So I've been working up a bid for Nottingham to hopefully have some telemedicine options moving forward, which actually we'll discuss because the models are developing. And we are looking at how we can support patients in terms of offering some aspects of this, and more importantly, obviously the why and things. So hopefully that perspective you guys are going to get and be able to see and listen and things.
Excellent. So I'm not an expert. Gandhi might be more of an expert, but I guess we're not experts. This is our opinion. So
agreed, definitely.
Make your own minds up when you've got more of the facts, I guess.
And don't forget to give us your comments. We're really interested in hearing what you guys think about this. We know this is a slightly controversial topic for many of you out there.
Absolutely. So why video consultations? How have we got to the point where we are talking about video consultations?
Well, I guess the first question to ask, Andy, would be, is there actually a demand for video consultations?
That's a very good question. So, and I've thought about this myself as well, because clearly people who control the flow of capital and investment think that this is a hot topic, because people are putting money into companies that provide these sorts of services, and they often know what's going on, so they must know something about demand. When I've spoken to people who are actually experimenting with video consultations within their own services, so I'm thinking, I don't know whether we should mention names, but I think Cripps Health Centre have been doing some video counselling around some of their student services, and they sort of report, well, demand's not that high. People often they want to come in anyway and see their clinician. So I'm not sure about demand. I don't know. What's your opinion?
I think, like you said, a lot of this has been driven by the perception that this is what people want. And I think that's because technology has developed to the point where it can offer it. So if you go back about 5 or 6 years ago, and many of you may not remember this, but 3 were the first cellular network to offer video methods as a communication, and they had it integrated in their mobile phones. And everyone thought that this would be an amazing thing. And it stalled for about 2 years.
Or longer.
And then all of a sudden it kind of exploded with Skype, actually. So it was Skype that took it a bit further, because people started to communicate and understand the power of being able to communicate over a video platform. And then once that happened and it became more accessible, people then started to realise actually they do want to talk. So, and things like WhatsApp calling, video calling, and that kind of stuff, and all the other kind of methods. So FaceTime was obviously a big option and things. It developed a lot more, and that's when people started thinking actually this may be something to be revisited, and the prospect of offering healthcare through that medium became a lot clearer because the technology now became a lot easier to do. You weren't tied down to webcams, you weren't tied down to having a specific location to offer it from. You could do it wherever you had a laptop or a mobile phone or whatever, and a data connection. I think that was the other thing, the data connection speeds, once they kicked up enough to people allowed to have video.
And the quality of the cameras and all of that kind of stuff too. Interesting. Another thing I think is, I think it's technology. It's a little bit sexy. It's quite visible. And if you're a policymaker and you want to have a new idea, or you want to be seen to be doing something new and different, then it's something that you can talk about and promote. So I think part of this maybe that it's popular with policymakers.
Definitely.
I wonder if they're driving.
I think that's partly because of convenience. I mean, it's no secret that our current Secretary of State for Health and Social Care, Matt Hancock, is
Hi Matt.
Clearly behind the technology advances and how that may work with the NHS, and he's made no mistake that he is a user of this kind of platform, and that he finds it really useful. So part of that, I think, is pushing the drive within the NHS to try and look at it, because the guy who's in charge of the NHS really, really likes it. Oops, sorry guys.
Goodness me.
First gaff. There we go.
Treat for the guys on YouTube.
I think that's why we're seeing an increased look at it, because definitely people are more interested. The policymakers, like you said, Andy, are a lot more interested in it, and there seems to be more funding and opportunity to develop it going forward.
Absolutely. An important question, so this is related to why. So what problem does it solve? Is a question, because I think in healthcare people are grasping to solve this capacity problem.
Definitely.
In terms of not enough GPs, nurses to handle the demand. And they're grasping, and sometimes what they're getting hold of is things like video consultations, which in my mind solve an access and convenience problem. In terms of they make it more convenient for people to talk to their GP, but they don't make it necessarily that the GP can see more patients per hour. They don't magic GPs out of thin air. So I think it's always really pertinent to ask what problem are the policymakers trying to solve? Do we have a convenience problem, or do we have a capacity problem? What do you think about that, Gandhi?
So I think that's the key distinction that people need to make. So you still need somebody to do the consultation. That's the key thing. And how long does the consultation take? I think there's this general view that video consultations and phone consultations are quicker than a face-to-face consultation, which may or may not be true. And recently, it was about a year or so ago, there was a study that came out that showed that telephone consultations was not, in terms of workload, more effective than face-to-face consultations.
I remember that.
And that's because whilst some of the consultations may be dealt with over the phone and that kind of stuff, you then, for a proportion of those, still have to bring them down for you to see face-to-face, for whatever reason that may be, because you need to see them, because you need to examine them, whatever that might be. Video consultation obviously has the benefit of being able to see the person, so certain types of consultations will definitely lend themselves better. Obvious ones, dermatology, so looking at people's skin, that kind of stuff, you can now do that over a medium and say, actually that's fine, actually we need to get some more stuff done and let's do it this way. And obviously that does depend on the quality of the images. But the question of does it solve the time aspect, that's the part no one's been able to clearly answer. And the general view is it probably doesn't. It does, however, deal with convenience.
Which is an issue, which is good. I mean, obviously we're sat here, we're GPs, we're thinking about our time, but patients value convenience, being able to do this thing from your workplace at your lunch hour without having to travel to the GP surgery, can perhaps save having an afternoon off work. So that is important, and we shouldn't lose sight.
And actually, both me and you as GPs, for me, if I wanted to go see my GP, that means either taking time off work, so I'm pretty much working all week long.
They work the same time we do.
Yeah, exactly. so having the opportunity I can, instead of taking the whole afternoon off, I can take off, say, for example, half an hour, so I'm free and available at that time, and I think it is a lot easier, and I can shift things around a lot better to do that, depending on what that may be. So we can definitely see how the convenience aspect is useful. I think one of the key things that always comes up is convenience more important than capacity when we're in a current state where the NHS is really struggling? I think this is the key question that always comes up.
think so. So, right, Gandhi. So the question why, often followed by the question what. So you've done video consultations.
Yeah.
So I guess without spending too much time going through it, just talk us through what happens from. So you work with Babylon. So talk us through what happens in terms of the patient experience of that consultation. So I'm a patient. I'm feeling unwell.
Yeah.
I've got the phone in my hand. Right. What happens?
So the patient logs into the app. They then say what is the issue and stuff, and whether they need an appointment. Different providers will have different ways that they allocate that and stuff. But either you will be given a time, or you'll be told when the next available appointment is, and you can hang on until that comes. And some companies are claim to have very good outcomes. So one of them, for example, like Babylon, says I think it's 34 minutes. Apologies if I got that wrong. Yeah, you will get an appointment within that time frame.
Quick.
Which compared to I guess I'm happy to say this in our practice, we can't offer that level of capacity. We can probably see you quickly if we need to. Whether we could guarantee to see you in 34 minutes for every kind of consultation, I'll be honest, no, we can't commit to that. So then the patient logs in, and then, for example, if they have an appointment at 10 o'clock, then the clinician that's offering that consultation will contact them through the app. So it's not a phone call as such. It may be a phone call, because it does certain things you have to remember. So things like data quality has a huge impact on this. So if you happen to be in the middle of a central building with no data reception, they're not going to be able to contact you. So either you need Wi-Fi or a reasonable connection. And if that connection isn't good enough to offer video, it will automatically default to a phone consultation. So that's one of the ways that these systems work. And then you have a consultation at that point, whatever that may be about the health issue. And inevitably, that there are various different outcomes of that. One is that you're okay, and it's just advice and stuff that needs to be given. Two, that you may need some sort of treatment or investigation, and then that's either organised obviously by the clinician, or if it's something that's available over the counter, you may be told to go over the counter and that kind of stuff. Or you need some sort of physical appointment as a result of it, because actually what you're saying doesn't mean that they can manage that either safely or appropriately through the medium of a video consultation. So, for example, if you have a possible lung infection, then you may need to have your lungs listened to, in which case it's a bit hard to do that with the current technology that we have. There is some prospects of that changing in the near future, I'd say. It depends, but realistically, for the common person, at the moment that's not really a factor. But you may need to be seen at the end of the day, and then it's a case of booking that appointment depending on the severity, urgency, all that kind of stuff from there.
Okay, cool. And what did it look like from the perspective of the GP? So
it's quite interesting. If you've never done video consultations before, it is a completely different way of approaching it. Okay. So many people, so a lot of our colleagues out there that will probably listen to this have no doubt done face-to-face consultations. It's the nuts and bolts of general practice. It's nuts and bolts of healthcare. Majority, I would say, have probably done some form of telephone consultation. And what you will automatically recognise, it's a different thing completely. So when you have a telephone consultation with a patient, you immediately lose the non-verbal communication by having somebody in front of you. So you do have to adapt the way that you offer a telephone consultation. If you don't, then you're not going to be very effective, and you're probably just going to bring everybody down from face-to-face, which kind of defeats the object. With video consultations, because you're looking at through a different... So one, for example, is you actually end up looking at the camera, not the screen. Because if you look at the screen, you can automatically create a disconnect by looking at the patient, because you're not looking the patient in the eyes. So, people watching us on the video right now, me and Andy obviously don't look at the camera all the time, because we kind of need to have the engagement between us.
We do. We need to look at each other.
And that means that you guys watching us may have some element of disconnect, because we're not looking at you all the time. So, it's that kind of thing. And a great example is if you ever Skype one of your family members, look at where their eyes are looking. Majority of people look at the screen because they want to see the screen, but then you kind of think, well, they're not looking at me. That's true. When you're consulting, particularly from a healthcare perspective, and especially for those slightly more empathic consultations, that can create a rapport issue. So it's one of the things that you need to consider.
Yeah, I'd not really thought about that, but yeah, I can see that. Yeah, the temptation must be to look at the screen and talk like you're on the telephone, but you're not. You need to be making that connection. Yeah, so that's interesting.
So that's one aspect. There's various different ones and stuff which more than happy to talk about in a different medium, but that's more like a tutorial kind of thing. That
maybe that's something you could do, or talk about it in more depth at some point. Who knows?
Yeah, why not?
So something that interests me about this is it's something that a lot of private money is getting behind.
Okay.
And so they obviously see the potential here for something, and they want to make money, don't they? So I'm just wondering who's out there and what kind of different business models are they applying to this problem or to this solution that's looking to find a problem. So we've got people like Babylon, Push Doctors, ZoomDoc, all sorts of people.
Yeah.
Are there any themes in terms of the business model?
Okay.
Are there different camps?
Yeah, so there are clearly different ways that you can approach this. One model to talk about, which is probably the most well-known one, is the Babylon model. So they were one of the first companies to go mainstream in terms of offering video consultations to UK-based patients. One thing to remember, America and other areas of the world have actually been far ahead of us in some aspects of this. So because of geography in America, video consultation has been around for actually about 3 or 4 years now on a more mainstream function. In actually, surprisingly, some people may think, areas of Africa and stuff, video consultation is used in a completely different way for offering access to healthcare in obviously areas where they don't have great access and stuff. But we're going to focus on the UK models because, we're in the UK. So Babylon, their model is based on their 2 different arms. So they've got a private arm, and more recently, as of last year, they've got what's called the GP at Hand arm. Now, we've covered aspects of this on numerous podcasts in the past, so I'm not going to go in great detail, but the key aspect is that they offer video consultations either to private patients that sign up and they pay a certain amount per month in order to access that. They do also offer that through their business partner method, so insurances, perks as an employee and that kind of stuff as well, or health insurance. And then their NHS version is that you register with their practice, and then you are offered, as part of that access, a GP at Hand consultation. And the reason why this model has been slightly different is it changes your registration of your general practitioner. So if you are a London-based patient and you are registered with your local general practice and you wanted a GP at Hand consultation, so to be seen on the NHS, by logging in through the app, you are automatically changing your registration to the practice that supports the GP at Hand model.
So why should I worry about that as a patient?
Well, I think it offers some benefit because you've got the telephone, you've got the video consultation method. But the key thing is, if you then need to be seen face to face, you would have to go to one of the hub centres that Babylon have, which may be that particular practice in London. And I apologize, I've forgotten where. But they do also use their other hubs throughout London. So they've got, I think, 4 or 5 hubs. Again, apologies if I've got this wrong, throughout London. The issue will come is if you're not a London-based patient, because at the moment, they don't have any hubs outside of London. So, you may be talking to a patient, for example, in Wales, Sheffield, Nottingham.
Okay.
Yeah. And if they then need to be seen, there's not the physical capabilities of being able to see that patient.
So what do you tell them?
So I've not really been in that situation whilst I was working with them. Pretty much everyone I saw was London based, and effectively not had to come across that. The general comment is that actually patients shouldn't register if that was the case. Some people do though, and it obviously then causes a disconnect. I guess part of it comes down to urgency. So clearly, if it's an urgent thing, you would have to safety net appropriately and say either you need to go to a walk-in centre or an A&E centre. If it's not, then you may just have to say you're going to have to register back with your old GP.
Just see your old GP,
And some patients don't like that, if I'm being honest. I could clearly see that may not be something they're happy with.
It lengthens their patient journey, I suppose, doesn't it? They say, okay, well, why did I bother with this, I suppose, if all you're going to tell me is to wait in line at my GP surgery. But yeah, okay. So that's interesting. So I'm getting the sense that there are 2 broad business model approaches, I guess. So one is private patients either paying subscription, paying directly per appointment, or through a partnership with their employer or insurer to get paid for access to video consultations. And then there is, maybe there's 3, and then there is this model that GP at Hand came up with where you can register as an NHS patient. The money that practice gets from the NHS to care for you over the year pays for your video consultation, and that's where the funding comes from. I think some of these companies are doing partnerships now with groups of GP surgeries, which I suppose is probably the final one, just to get some more detail about.
Yeah, so there's other ways that practices are working with issues. So there's other companies, for example, like Push Doctor or Now Healthcare, that have partnered with large groups of surgery. So people like Modality, and unfortunately I can't remember the other one. And they basically offer a video consultation service to any patient registered at those practices. So kind of same principle, but it's just, I guess the slight difference is in order to access the app, you would have to be registered at those practices. So that's currently an offer that's going out to their patients. It's kind of the same thing, because if you wanted that, you'd have to change your registration to the practices again.
Yeah.
But that's a different model in the sense of the way that it's initiated and things. Very similar to the Babylon one, but slight differences. The third model,
fourth, we're on four.
Okay, fourth model is the other prospect of offering a hub and spoke kind of element. So this is where some companies are offering services to federations of practices or networks. So the new buzzword in primary care is going to be primary care networks.
PCNs.
Yeah, or neighbourhoods. Actually, I think they're also rebranding it again to neighbourhoods.
I think I prefer neighbourhood.
Well, we'll see what it ends up being, but groups of practices. So you have super practices, massively large. So, I'd probably say Babylon counts as one of those, with the GP at hand. Modality, what's the other one? Our Healthcare, is it?
Our something like that. Used to be Vitality, but I think they're Modality now.
Yeah.
There's another big one in Birmingham. We'll add it in the show notes.
Yeah. So large practices like that. But then what's increasingly happening across the UK is that practices are actually coming together as part of what we call federations, to offer a variety of services and economies of scale that can help practices function, but at the same time aligned principles to offering what they can for their patients and things. And there's various different levels of that in terms of hard partnerships where they have the same kind of rules, protocols and regulations, and soft ones, which are just groups working together for a combined aim, but they don't necessarily have to do the same kind of thing. But one of the models being offered by some areas is that they are having, in effect, a hub and spoke. So the spoke is the individual practices where you are currently registered with, and the hub is a central centre that offers the video consultation aspect as either a first protocol or an overflow possibility that patients then have access to as part of their membership with the practices, that doesn't change their registration in terms of where they're currently being seen. So the practice will still get their capitation money, so the money that practices get for a registered patient. But in terms of using that service, they can still access or use that service. And that obviously has some benefit because it tackles a particular cohort of patients, typically the working well or the more able, that kind of thing, that have that preference for video consultations and stuff. But doesn't just damage the.
So it doesn't remove the funding associated with those patients from the pot of money that has to pay for everybody's care, including frail, elderly, type patients who perhaps need to see their GP face to face more, and are less inclined to use these new technologies. So it's less destabilising. I guess.
So there are a couple of companies offering this potential kind of model. So there's a group called Livy, which is I think it's a Scandinavian company originally. Honestly, apologies if I got that wrong. And they're based in Surrey, I think it was. And they're offering a system down there. Another group called Q Doctor, offering a similar sort of services across the country. Again, private to some degree. I think most of these companies have private arms as well, but are starting to offer NHS-based care via this model of a kind of overflow, hub, spoke kind of element.
Yeah, I got the impression that these companies are sort of adopting a business model of almost selling their nuts and bolts and shovels to federations, GP practices, so they can run these services more for themselves or in the way that they would want to run them. And I'm quite excited by this way of doing it, actually, because I think it keeps the ownership of the process with people's GPs. People tend to trust their GPs, still rate highly in measures of professionals that people trust, and it allows them to deal with these to continue to use the funding they get to deal appropriately with the different types of patients, but also offer options to their more perhaps less complicated, more inclined to use video patients. So I'm I'm a fan of this model. Not that I'm not a fan of the others.
Yeah.
I think they've got their place, but most excited about that, I think.
Cool. And fifth model is slightly different. So it's the more home visiting model.
Okay, yeah.
Yeah, so there are some companies out there that offer a more concierge style kind of GP method, which they would potentially visit you at home. As far as I'm aware, none of these offer this on the NHS yet, but it's a paid for and private model only. But they are companies that, as far as I'm aware, do also offer some element of NHS care as well. So these are companies like ZoomDoc or GPDQ. Interesting, if you want to have a look, we interviewed the owner of ZoomDoc back, this time last year, I think it was.
Oh gosh, long time.
So do feel free to have a listen to that interview to hear more about ZoomDoc back then, but obviously that was a year ago. I think that
maybe we should check in with him.
Yeah,
see how things are going.
Yeah, why don't you update us, Kenny? See how you're getting on. But yeah, so they offer a more it's a geolocation system whereby if you wanted to visit, you'll have a GP local to you that then comes out and visits you, and you are you would pay for that consultation. As I said, I think both of these companies do offer other aspects of care interlinked with some of the other models that we've just talked about, but that's also a separate kind of arm to things. Probably more prevalent in the metropolitan cities like London, Manchester, Birmingham, that kind of stuff, but available pretty much across the country.
Yeah, and of course the flip side is it's offering GPs other ways to work as well, which a lot of GPs will be happy to have. Right, let's leap into potential problems.
Okay.
So we're going to talk about there are positives.
Definitely.
So we're going to talk about the positives later. But there are potential problems. I'm going to kick us off with one, which is related to this workforce issue, because we've already alluded to the fact that there aren't enough GPs to recruit into surgeries to carry on day-to-day service. So that's certainly how it feels in many areas of the country. And what a lot of these models are doing are providing patients with a much easier way to pay for GP time to see them privately. So is there a danger that what we're doing is sucking up some of that rare workforce away from NHS work, which is often dealing with perhaps potentially more challenging, more complicated, more long-term frail patients, those people who need the continuity. It's taking the people who could do that work and perhaps paying them a little bit more to do less challenging work, sat in their own bedroom, comfortable environment, who wouldn't potentially want to do that, particularly if it's paid more money. But is that good for the overall health system? So is it further exacerbating the workforce issue? My question to you, Gandhi.
I think that's a hard one to specifically answer, but I think that it definitely raises concerns. And like you said, I think a lot of the people that are less happy with video consultations as a business model would say that's one of the big issues. That all these people that are now offering video consultations are not able to offer nuts and bolts, primary care, NHS appointments and stuff, and that's what we're struggling with. We were promised 5,000 extra GPs by 2020. That's now been realigned to some point in the future. And whilst VTS placements are full at the moment, that still doesn't mean we're going to get that level of GPs anytime soon. Skill mix is obviously something that's been worked on in terms of trying to offer a workforce solution, but it doesn't change the fact that we are actually losing more GPs at this moment in time than we are currently training. So the question is where that workforce is going, and one of the views is this is the avenue that people are taking because of either, I'd probably say, more work-life balance than pay. So having done the job, I actually get paid more easily working as a locum in a practice, and I would say I definitely get paid more working as a partner compared to what I was being paid by Babylon. I'm not by any means saying they weren't paying enough. For what they were offering was equivalent to the market rate, I would say.
There's a book coming.
No,
there's no book. Okay.
But I think there's this perception that you get paid more.
Okay.
I think I'd say that you get paid equivocal. There are some ancillary benefits, so they do give a lot of perks of being a member of their company. So things like healthcare, that kind of stuff. That's as a salaried contract, it was equivocal to what I would potentially get if I was working in a practice, but just slightly different benefits in different ways and stuff. So, for example, if you work for Babylon, you get to use Babylon for free. A slight perk kind of thing.
Okay.
And all the other companies have similar sort of kind of offerings and stuff in terms of costs and stuff.
I can dig that.
So the question about money, I think is not the real question. It's more about work-life balance. It's that thing of being able to work from home when you need to being able to potentially sign on at any time, depending on the demand aspect of things. But you can book, if you realise, all of a sudden I'm not doing anything on Friday, I can sign on and work on a Friday last minute kind of thing if there was the need. So there is that easier aspect of arranging work for what you might need.
Yeah, I can dig that, and I can see how you might liberate spare capacity within the workforce. People working at short notice, people filling little bits of unexpected time. So I guess there's a positive element to that side of things. I still think there's potentially an effect on the workforce that people aren't potentially addressing enough.
I agree. I think whilst there's definite positives of that. I think some people are right in terms of saying that we've lost an element of workforce as a result of that. Is that because the current system doesn't offer that level of, there's always this whole question of the millennials coming through and how they view work-life balance more importantly than money, or, to a degree even the service of the NHS, which is what many patients and politicians would say is an important
That's a controversial thing you potentially said there, Gandhi.
Well,
millennials' values not in the right place?
I didn't say that at all. They're different to the baby boomers.
I'm feeling like Jeremy Paxman here.
Fair enough. I would say that I don't think anyone would disagree that the viewpoints are different. And this is by no means on an individual basis, so before anyone starts shouting and trolling at me, this is a generalisation. Completely agree with that. But, it is not uncommon to hear this kind of prospect that the millennial viewpoint.
I'm going to come at this from a different angle. Are their values more in the right place? Potentially.
Yeah.
In terms of looking after themselves.
We often talk about burnout, resilience and all this kind of stuff. And
maybe we're making generalisations about millennials, but also there's nothing wrong with, making sure you're okay to make sure everyone else is okay. So, interesting. Yeah, there's a whole other conversation to be had there, I guess.
Yeah.
So other potential problems. And some of these are obvious, aren't they? So continuity. Are you, somebody who perhaps needs continuity? Are they going to get that from a video consultation provider?
I think this is one thing that is worth talking about. So, if you're working through one of these systems, by no means are you likely to see the same patient twice, because it depends on when you're working for the service, how often you're working for them, and same for the patients. The benefit is that you can access it when you want. It doesn't necessarily mean that you're going to see the same doctor, because they probably are not going to be working at the same time. It does vary. So when I was working for Babylon, I did 8 hours a week. The reality is the patients I may have seen at the start of when I worked in them towards the end may not be able to book with me because I'm only available for 8 hours in the week itself. And therefore having an opportunity to speak to me at that time, that does mean the continuity changes. Now, some would argue that's potentially a good thing because you get different opinions. You can also argue it's a bad thing because you don't have that knowledge. You're having to play catch up again, reading the notes, taking the history all over again, trying to understand the perspectives. You may get some, may not get some. And then there's this third aspect, and it's a really interesting phrase called the collusion of anonymity. Anonymity.
Yeah.
So for those of you that haven't heard this is a theory that when you see multiple people, some will assume that aspects of your healthcare are already being dealt with by the other individuals. So they may not get addressed fully because of the prospect that they're being dealt with by somebody else. And it's a criticism that's often given to places where continuity is not a factor. And there have been recent studies that show that continuity is probably one of the better things to develop health outcomes. I can't remember the paper off the top of my head, but I think it was about 4 months ago, if my memory's correct.
Okay, I think I remember it coming out as well, but I can't remember the details.
But saying that basically for continuity is the key driver for improved health outcomes for patient care.
Yeah.
So
harder with video consultation. I mean, maybe that's not what it's for. Maybe
it's this question of continuity versus access.
Yeah.
If you can't speak to a GP when you need to, what's more important compared to seeing the same person?
Yeah, and some types of patients, access is important. Some types of patients, continuity is important. Maybe there's another streaming that
and there are definitely aspects where continuity is important, and there are definitely aspects where continuity is not really important at all. So if you are a generally healthy person and you have a cough or a cold, realistically, continuity is probably less important than if you are a patient with a chronic disease like COPD, or other health issues and the same sort of symptoms, because then actually the continuity, seeing the person that knows about your background health issues, what's been done before, not been done, that kind of stuff, that's potentially more important for that particular episode of care. It does vary. Yeah,
right. So my next potential problem,
okay.
It feels like I'm raising a lot of these. Right. So, I'm not feeling very well. I've got a sore throat. I've had it for a few days. I'm me, so I'm in my mid-30s. I don't necessarily have other health problems. Am I going to go to the GP? Well, it means ringing up in the morning. I'll have to wait on the telephone. Then I'll have to probably wait a few days for an appointment because they won't think I'm that well, and then I'll have to go. I might have to take the afternoon off work. You know what? I think I'm not going to bother my GP. I'm going to take my chances and see if it gets better on its own. But wait, I've got my phone in my pocket. I've got an app there. I can have a speed dial straight to a video consultation, or I can go to work. They're going to have a video consultation in my lunchtime. Suddenly it's a lot more convenient. You know what? I think I'm going to talk to my GP about this. So does it drive demand, I guess, is where I'm getting at. Are we opening a can of worms here? And people who would not talk to a GP or prescribing nurse or whatever about their particular problem, are they going to suddenly think that they want to now, or that it's appropriate to now, when they'd probably be okay? That's a concern that I have, driving demand. Yeah. Do you agree? Or
definitely.
You agree?
So we talked about this briefly actually in our last episode about the NHS app in terms of access and stuff, and we talked about, does having a method of communication that's more instant therefore help to drive demand, or more importantly health anxiety, I think was the other aspect that we looked at, and I think it can do is the answer to that. I think for some patients it's not going to make a difference, but there is this perception, and I don't know if there's any evidence to back it up, so I'm being honest here. Does it actually drive demand? The general view, I think many people say, is yes, because increased availability of access means you're more likely to come. And I'd agree with that on a subjective point of view, because I know that when we did sit and wait clinics where you are guaranteed an appointment if you turn up on the day, that meant that I was seeing people that have had a cough or a cold for 2 hours.
We did a trial of something called Doctor First, where we offered, no cap on the numbers. Anybody who says they want to speak to a doctor today can speak to a doctor today, and we'll triage you on the telephone. And when we started doing that, we were seeing each doctor's got maybe 40, 50 calls to make a day. After a few months, it was over 100, and we had to pull the plug on it. And we were talking to people who'd had healthy people who'd had a cough since that morning because they had access. So again, I agree, anecdotally, it seems that way. You know what I think as well? I think this is something that is potentially known to some of these companies. Because if you think about the sort of data they have, so Babylon, they know someone's usage frequency when they first start using the service. They know what it is after a year or more now. I'd love to know, does it become more frequent? On average, do users use it more the longer it goes on? I'd love to know that. We'll probably never find out.
Maybe not.
Be interesting.
But you're right. I think that question of does it I think our view is that it would increase access, increase use, not access. And that's obviously a question mark in terms of how that is managed in the longer term. Are we then creating a cohort or a generation of people that don't take as much responsibility for their healthcare because they don't need to, because they can defer that responsibility to a healthcare system? Yeah. Big question.
Big question.
Yeah.
We're
not going to answer that today.
I don't know the answer to
Maybe
that.
a future episode.
It's a danger, though. We're highlighting a danger.
Definitely.
So I think we've... I'm just looking at our show notes here. We talked about destabilising business models, but we talked about that earlier with GP at hand and the risk of drawing away the funding for the healthy. People on YouTube can see my inverted commas. Draw that funding away from the more frail.
I guess just to explain that a little bit more, if you've not heard our previous episodes and you don't know how general practice is currently funded, effectively your GP practice will get a set amount of money, which is approximately, when you include all the extra things, about £135 to £140 per patient per year. They get that no matter who you are, effectively. So if I have 10,000 patients registered at my practice, I get approximately £145,000 a year to offer healthcare to all those patients. Is that right? My numbers?
I'm not sure, but anyway,
the
principle will ring through.
Okay, so you have X number of patients, you get, say for example, £100,000 to look after them per year, irrespective of how many times they come to you. So they could come not at all, or they come once a week, to use the practice, and we get no extra money. So to be clear, your GP does not get paid for the number of times you come to the practice. The issue with that is that you use the healthy people that don't come that often to offset against the more people that with chronic conditions, like potentially the elderly, young children, people with complex health needs, the amount that they use, and that's how it's balanced. That's called a capitation health system, and that's how currently all NHS practices are funded. By taking away the people that don't generally use the health system because of the convenience aspect and stuff, or for whatever reason, you're making the costs go up because the income's going down.
Yeah. So I guess what you're saying is, if you're a GP practice in London, and then GP at hand perhaps come along in your area, and you're fairly fit, fairly healthy people who are kind of in that middle-aged category. They're not young, high frequency users because they're children. They're not elderly.
Yep.
They're in the middle. All those people like using smart apps and video consultations when they want to see the GP. They go and register somewhere else. They take their funding with them, and you're left with quite frail, complicated patients, and you're not able to offset the amount you spend on them with the money you get for the healthy people because they're all registered somewhere else. So it's destabilising potentially.
Yeah. And to be clear, so that's not to say that Babylon are wrong in what they've done necessarily, because they haven't broken any rules or any kind of regulations or anything like that. They're using the current system. So there is a look being done in terms of re-evaluating the way that GP practices are paid because of this. It's highlighted basically a big glaring loophole, effectively. And that is being looked at. What that answer will be, we don't know. We'll obviously find out at some point in the near future.
I think Babylon would probably happily accept that they're disruptors. They're shaking up the industry, and the industry is going to have to adapt
like what Amazon did to booksellers about 10 years ago.
Yeah, and maybe the industry will be better for it.
We'll find out.
How's the local bookshop doing, Andy?
Well,
it's got a coffee shop. Yeah, and it's doing all right now.
Yeah,
but it went out of business for a while. Yeah, in the middle.
Okay.
Positives. Yeah. So I think there are positives. So we've acknowledged all along, we're GPs, but patients really are the centre of this. And if this makes it more convenient for patients, and it's something that patients want, then we should probably provide, and they benefit from it. We should probably be providing it. We need to make sure that the system can cope. That we're using the resources correctly. That it's not going to bankrupt GP practices, but that's our responsibility. Maybe we need to get all that in place. Maybe operating as federations is the way to do it with that model. But maybe we should offer it. It's good for patients, so that's a positive.
I mean, we talked a little bit about the positives as well. So in terms of the kind of like the convenience, we've already mentioned that one as well. And we talked about the difference in spend in terms of private and NHS sector as well. I mean, did you want to elaborate a little bit more on that, Andy?
Oh, right. Yeah, so I guess if a patient... so essentially what we're doing here is we're taking patients who might use the NHS, some of them, and because there's a convenience service offered by a private provider, they'll pay £25 to have a video consultation, with a private provider. That's a consultation that doesn't take place within the NHS. NHS has saved money. Patients perhaps happy, feels more empowered. They're paying for a bit of icing on their own healthcare. Is that necessarily a bad thing? There are potentially some problems behind the scenes, and how do the notes get reconciled back? But at face value, we're perhaps moving some of the responsibility onto higher earning individuals who want to pay for convenience away from the NHS, who can get on looking after the needs rather than the wants, and maybe that's a good thing.
It raises the question of widening health inequalities, which I think is one of the other concerns that this kind of the system would have. So, like you said, if you can pay for it, you get access. But then, what if you can't pay for it?
That's tier 2 NHS only. That's where you go. Yeah, potentially.
Which is why a lot of people are worried about this developing, I guess, into the American healthcare system. That's not necessarily to say it's all bad. The American healthcare system does have some of its positives. It also has some negatives. But yeah, it's interesting. I think one of the key positives, though, is that it brings the opportunity for innovation. For changing the way that things are currently done. And we talked about that with Babylon potentially being a massive disruptor to the primary care, healthcare systems and stuff. And again, that's not necessarily to say that disruption is bad. I think, we've seen paradigm shifts happen as a result of that. So, yeah, again, Amazon's a great example of a disruptor. They came in, they massively changed the way that people use online shopping and that kind of stuff with their models. And yes, definitely there have been some winners and there have been some absolute losers out of it. But it's the change in the way that we live. It's that aspect of things, isn't it?
You know what? With Amazon, I'm a customer.
Yeah.
And I love Amazon.
Same here.
I love Amazon because I can get what I want. I can get it soon. I can get choice. I can see what all the other users thought of it before I buy it.
Mm-hmm.
So I'm perhaps not so worried about the bookshop or the toy shop. And we're perhaps sat on the other side of the fence here, being the GPs and the patients being our customers. But it's not necessarily about keeping us comfortable the way it is. Maybe things need shaking up.
We'll see.
And positives. I think that the true potential of video consultations comes when you roll them up with the other innovations that we've perhaps been talking about on the podcast. If you integrate them with a system that includes some electronic triage, perhaps there's some artificial intelligence in there, perhaps there's some near patient remote monitoring capabilities. We talked about the Alive Core thing. Perhaps mobile phones will integrate more patient monitoring features to do observations and so forth. You've got the video consultation there if necessary. You've got options for face-to-face assessment, sending out paramedics, travelling to a centre.
Definitely.
If there's a system where all of this is integrated, then maybe that's how we actually handle people's health needs much better. So maybe it's actually part of a system rather than being a solution itself.
The reason for that is been highlighted by actually one of the original uses of video consultations in the UK. So one of the drivers for this kind of method was actually how do they deal with the healthcare of inmates, people incarcerated and stuff. And the reason for that is if you needed to have somebody who's currently in prison and needing healthcare, most prisons have some on-site nursing or healthcare facilities, but there is obviously a limit to what they can offer. So therefore you need to transfer that person to a hospital to see a doctor with more experience or in whatever setting. That obviously brings in risk, costs and all that kind of stuff. So actually, some areas, so where I used to work up in Airedale, hi guys, hope you're listening, hope you're enjoying it. They created an innovative system whereby they offered videos consultations to several of the local prisoners by the A&E consultants, so real high level of expertise, and they would assess them through a video consultation method. Clearly not what we're talking here, but that method meant that significant amount of savings were being able to make because, particularly for that, the more, I can't remember the term actually, but
I see where you're going with this.
Some of these prisons potentially may need, systems like diversions, that kind of stuff to transfer them out. Significant amount of police,
costs. The resources must be huge to look after someone in hospital.
So therefore, to offset the need for some of that, often because you're getting a high level clinical opinion in terms of whether they genuinely do need to come out of the prison system or whether they can be managed safely. That's potentially a huge cost saving to the taxpayer who's paying for all this at the end of the day. So that was a huge benefit that was seen, and clearly that has power. And I guess that's where a lot of the adaptations have come in terms of it now being used more mainstream in primary care.
Interesting. So, Gandhi, are you doing anything to prepare for this at your GP surgery?
So, as we talked about earlier, I'm actually working up a bid for Nottingham area to try and offer that. And this is potentially using one of the models that we've talked about earlier. And I think it has opportunity for practice because we know that practices are struggling. We know that healthcare demand capacity is a huge problem. And trying to solve that, if you can take away some of those consultations and divert them through a different route, whatever that may be, then that may help practice manage things and therefore be able to offer a better service to patients. We know that patients find the current system not the greatest in the world. There are definitely episodes where people are having to wait several weeks to see a routine GP appointment, and therefore the problem with that is then patients then say everything becomes urgent. If everything becomes urgent, then nothing is urgent.
So you're talking about streaming patients more effectively.
So I think there's definite benefits. I think the key thing, though, is to remember what the consultation is being used for. So one of the negatives we didn't really quite look at is the profession perception that you may inappropriately manage a patient because of the medium that you're seeing them through. So the classic one is antibiotics.
We didn't talk at all about safety, did we?
No, we didn't.
That's
I just realised we forgot that.
Yeah.
So the classic example that comes up is a patient make a consultation for an upper respiratory tract infection, and the outcome of that is they get a course of antibiotics.
Had they been seen, they might not have got the antibiotics.
So the question is, can you accurately assess that through a video consultation method? For some conditions, yes, I would say, but for particularly the lungs, the question of is that the right outcome, many would often say that you would need to examine the lungs clearly to have a good idea. I think there are some situations where it is appropriate. So if you've got, for example, a COPD patient who has chronic recurrent infections, then clearly that is the most likely outcome.
Balance of probabilities. Yeah, that's the right thing to do.
However, for a generally fit and healthy individual, the chance of them having a bacterial infection is fairly minimal, particularly in this country because we have such good sanitation and stuff compared to, obviously other countries abroad and that kind of stuff, which is often one of the reasons why patients from abroad tend to consult more often, because of the difference in healthcare origins and health beliefs. But yeah, do they necessarily need a prescription? Well, many would argue that if you're doing a proper, accurate professional assessment, you would need to examine the patient in order to make that decision in that instance. And if the outcome is that you get a course of antibiotics, then that may not be the correct outcome. And that's one of the concerns and criticisms. Interestingly, so if we look at one of the companies, so I've seen their data publicly, and that's Babylon, and their actual antibiotic prescribing rate is pretty much in line with most of the practices. Okay, so the perception that they overprescribe doesn't seem to follow through. Having said that, I've also seen episodes where that's definitely not the case as well. So I've had feedback from other providers and Babylon. No. So this is in my NHS job. We obviously get communication sometimes, and when I've looked at the documentation, I've kind of looked at it and thought, yeah, the documentation doesn't support the outcome. Let's put it that way. Okay. And so I've challenged that with then the providers saying, unfortunately, I don't see how this is. Can you clarify this in more detail, because we need more information to understand why that was the outcome. Yeah. And that's not to say that doesn't happen in other places. Patients often attend practices and they get antibiotics inappropriately. There's a huge amount of work being done in terms of out of hours, A&E. I often have some patients who may attend the practice, they attend again a couple of days later, and then because they still haven't had antibiotics for what they feel they need antibiotics for, they then go to A&E, and lo and behold, A&E have given them a prescription because it's the easiest way of managing the patient. Not saying that happens every time. I'll be absolutely clear on that. I colleagues in A&E, that doesn't happen all the time, but it does happen sometimes.
And in defence, sometimes if you're the second or third person seeing somebody for the same problem, then your perception of the risk of inaction can be different. So that might be driving some of that behaviour too, but I take the point you're making. Right, so, Gandhi, good or bad video consultations?
I think, so I obviously I've done this from the other side. I've been a clinician working, and I think it has some real power as well. I enjoyed some of those consultations. I was working with, the opportunity to speak to patients. It, to me, in some ways, felt no different to how I was seeing patients face to face, and it worked quite well in some aspects. I think there are definite aspects about it that are a negative, and my concern is more probably around the development of health anxiety and people using the systems inappropriately. The increased access means that people use it more when they may not need to. I think there does need to be some work being done about that. Otherwise, we will create a generation of people who develop hypochondria. Effectively.
Maybe we should do an episode on hypochondria and Dr. Google. That's a date. Let's do that. Yeah. So my opinion, I think I'm going to say good, but it's important that we understand the tool. It becomes part of a toolbox of other things that we can use to create the healthcare service of the 21st century. But we need to understand what that tool is good for, what it's bad for, and deploy it correctly. And I think that general practice needs to wake up a little bit and take ownership of video consultations, and that's probably in the form of their larger group practices or federations. But so good, I understand it.
The reality of saying that video consultation is never going to be a reality of primary care is the wrong view, and to try and sit there and say that it's not something I'm at all even going to engage with. I think the reality is that if that's the view you're taking, you may unfortunately as a practice go the way of the bookshop.
Potentially. That's quite a profound analogy and message there.
Okay.
So thank you for listening. It's been a very interesting episode. Gone a little bit longer than we planned, but hopefully it's been interesting for you. And Gandhi, at the beginning you said you'd talk a little bit more about Patreon.
Yeah, so as we said, guys, we do this work completely for free for you guys, and we will always maintain that our podcast will be completely and utterly free for everyone to listen to and stuff. But we would like to kind of have some support if that's something.
I would say, however, it may be free at the point of consumption like the NHS, but it does have costs. So as hosting costs, it's not free to run a podcast.
Yeah,
there's equipment costs. So get back to you, Gandhi.
Yeah. So one of the things that we thought we would develop is something called a Patreon model. So for those of you that don't know it, it's kind of like crowdfunding in a sense. Effectively, if you want to sign up and support us, you can do. We'll put the web link up in our show notes and stuff. But effectively, you can register to give a small donation on a monthly recurring basis to support us. As we said, we by no means are asking you to do this as a must, but clearly more than happy that if you would, because it shows us that we're doing something of benefit. Yeah. We do have a couple of tiers for you, so just simply to support us if you want to, $1 a month. It's in dollars because it's an American company, but the reason we're using it is because it works quite well and effectively, and it's clear what we're offering you and stuff. As an extra, something me and Andy are trying to commit to. So you're creating a new banner for.
So I'm doing a new banner for the Podblast, and this banner is going to incorporate some elements of our logo. We're going to do some caricature of myself and Gandhi. And if you sort of support us on the higher tier, this is a bit of an experiment. But if you're supporting us on the higher tier, then I will do a caricature of you to appear on the banner with Gandhi and myself. So Gandhi, how does this work?
So effectively, if you sign up to the higher tier, we will need you to provide us with a photo so that we can Andy can actually draw you or something. But then we will add your caricature into the banner so that you are there with us. Clearly, an appreciation from our perspective to show that you are part of our podcast journey, and that's what we're after. Actually, we want people to join us on this journey, and we hope that we are serving you all well in terms of offering you the information, the perspective, the opinions, I guess. Absolutely. At times, as well as what we're offering and the educational aspects that come with it. And as we said, your support is really valuable to us, and if you feel that we are good enough to earn that support, we would like to reward you as best as we can. There are potentially some other tiers going to come, but we need to make sure that we've got that right and appropriate for you guys as well. So that's where we're starting. As we said, the link will be in the show notes and stuff. And
check it out.
Have a look. Yeah.
So as we wind up, remember to give us feedback. We've had a good time talking about this issue today, but do connect with us on social media at eGPLearning, at Dr. A.W. Foster,
and at Dr. Gandalf 52. So we're both on Twitter and Facebook. I'm on Instagram as well as LinkedIn. And feel free to just message us if you want as well outside of that. We're both more than happy to talk about things and respond to comments. And also, if you've got something you'd like us to talk about, if you've come across, I think me and Andy are pretty good at picking up new things coming up, but we're by no means able to be omnipresent or anything like that. So if you've had some, tech or some aspect of primary care that you think is really worth having a look at, make contact with us. We're more than happy to look at it.
Take a look at stuff. Tell us what you want us to feature.
And potentially interview you as well. So we've got interviews coming up for you. I'm going to make a slight apology to our listeners. I said last time that I'd have the interview with Aisha Malik, the Business for Doctors GP, ready for you. Unfortunately, I've not had it quite ready because of a tech problem. But that should be coming soon. Apologies, Aisha. I know I said I'd have it ready for you as well. But it's a little bit more delayed than I'd like.
We forgive you.
Thank you.
So remember to tune in next time for the next exciting episode. Next time we will be going back to our roots, and we will be doing some app reviews and taking a look at health technology in the news. So that brings us to an end. So thanks for listening. It's goodbye from me.
And goodbye from me. And we'll see you guys soon.
Take care. Bye-bye.
Bye.
Okay, so that's the end of the podcast. So this is what happens afterwards.
So guys, we've finished recording the podcast. We're going to go off and do some editing of that in terms of making it sound a little bit better, possibly editing a little bits and bobs out. Actually, probably not a great deal. So bizarrely, that's probably our longest episode we've done. 1 hour and 7 minutes we're at. in raw footage.
No coughing.
Yeah.
Nothing that needs to be necessarily taken out. So that's good.
No, so I mean, based on our experience, that'll probably come down to about an hour and 5 minutes. So it is a long podcast. And for those of you that don't like long podcasts, we apologise. But actually, that was some pretty good content, I think.
Yeah, I think that was a good one. I enjoyed it. So that's good.
So yeah, we'll get that up and running. That'll be at the end of the month. That will be coming out to you guys. In terms of this raw footage, we'll actually post it at the same time. So it will come out at the same time, but obviously you guys get to see the more behind the scenes aspect of things. And actually, if you want to see more, let us know. So if you
maybe you want more of a tour of the editing, or who knows. But yeah, let us know. Give us some feedback in the YouTube comments below.
Definitely.
Right.
And yeah, let us know what you think.
That's cool. Right, so I'm going to see if the battery has held out and we're still recording.
Fingers crossed, you're still seeing us. All right, guys.
I will